Welcome. My name is Harry Mond and I'm a cardiologist in Melbourne, Australia at the Royal Melbourne Hospital, and I'm also Medical Director of Cardioscan, who is the sponsor of today's webinar under the endorsement of the Asian Pacific Heart Rhythm Society, APHRS. We have registrants from over 30 countries today, and at the end of today's webinar there will be time for a question and answer session, and you should be able to put the questions to me in the chat box. This hopefully is the first of a number of ECG sessions on the fundamentals of electrocardiography. Today's talk will be on aberrant ventricular conduction, which is an extremely important topic because both physiologists and cardiologists cannot often recognise this on the electrocardiograph, which in turn may lead to inappropriate medical intervention in patients. So let us start with the first slide. I would like to commence this talk by paying homage to Willem Einthoven, 1860-1927. He was the man that built the first electrocardiograph machine in 1901, and in 1905 presented the first organised presentation of normal and abnormal ECGs. As you can see on the slide, the machine was very cumbersome and the patient had the legs in buckets of saline water. At that time, we now had ECGs, chest radiographs, and of course the stethoscope. And they remain the main investigations that cardiologists used right up into about 1970, when I first became a cardiologist in training. Since then, there's been major changes in cardiology, with the introduction, of course, of echocardiography, CT and MRI. And today, the chest radiograph is rarely used, and the stethoscope has been placed at the bottom of the drawer, gathering dust in your office. So the electrocardiograph has remained the same. It's been in clinical use 120 years. It is still the first test requested and performed by a cardiologist or physician, and today is coupled to ambulatory monitoring with ever-extending indications. So the electrocardiograph has remained an extremely important tool in cardiology, but is often not given much emphasis in teaching and training. Let us look at an electrocardiograph. This is a Holter monitor recording. It is an obvious rapid heart rate. As you can see there, it's irregular and it's atrial fibrillation. Centrally to that, you can see a run of 6 beats of broad tachycardia, which has been noted by the physiologist to be a ventricular run. However, this has occurred as a faster heart rate of 190 rather than the average of 160 with the atrial fibrillation, and is not ventricular tachycardia, but rather is atrial fibrillation with aberrant ventricular conduction. Aberrant ventricular conduction, it can be defined as it's a change, usually temporary, from what is normal or typical. It was first described as aberrant beats in 1910 by Sir Thomas Lewis. Note that this is only 5 years after the onset of the first clinical information on electrocardiographs. Sir Thomas Lewis actually had a machine in 1906. He graduated from medicine in 1905, and he then described aberration soon after. On the electrocardiograph, there is QRS widening, usually a right bundle branch block, and it is a physiological response. I will repeat this a number of times during the presentation. Whereas a fixed bundle branch block is not an aberration, pre-excitation is not an aberration, and a rate-dependent bundle branch block is not an aberration. Rather, these are all pathological. In order to understand aberrant ventricular conduction, let us look at the footprints of an atrial ectopic. We can see here in red highlight, the atrial ectopic has a P wave beforehand, it's premature, and there is an identical QRS and a compensatory pause. Now, with aberrant ventricular conduction, such a premature supraventricular beat may be conducted to the ventricle during the relative refractory period or phase, and is a phase 3 block. The result is the QRS with a bundle branch block. It's often interpreted as ventricular. So let us look at the refractory periods. Here we can see the physiologic aberrant conduction with the action potentials of both the left bundle branch and the right bundle branch. And it is quite obvious, we can see that the right bundle branch is often, the action potential is often longer, or usually longer. This results in an absolute refractory periods being different for the left bundle branch and the right bundle branch, which is longer. As a result of this, we have phase 3, where there's the relative refractory period, and it is able to conduct. So now we have the left bundle branch able to conduct, whereas the right bundle branch remains absolutely refractory. And as a result of this, we have a premature beat may be conducted during this phase, and this is called the zone of aberrancy. There is QRS widening and the right bundle branch block. So now let's take an atrial ectopic and look at the changes that occur with aberrant ventricular conduction. Firstly, we can see in V1, we can see a P wave, and there is a wide QRS of a right bundle branch type, and we can see an RS uppercase R prime, which is the feature of aberrant conduction. And this here, the yellow red highlight, was first described by Barney Marriott, the cardiologist who taught me electrocardiography. And this is what he calls rabbit's ears. Of interest, there's another feature that I have noted over the years, and I've actually found in the literature, that V6 has a narrow QRS, as you can see in this illustration. So now let's return to normal conduction, and with aberration here, atrial ectopic, atrial fibrillation, both having the R prime in uppercase dominant. Whereas for ventricular tachycardia, we have the dominant feature is the R wave and not the R prime. Now, this is ventricular tachycardia with a right bundle branch block, but it is incorrect to use the term right bundle branch block because conduction is not via the normal conduction pattern from AV node through to the left bundle, but rather this is an ectopic focus and therefore has a different wave of depolarization. And if it has the features of a right bundle branch block, we call it a right bundle branch block configuration. So aberrant ventricular conduction is via the normal conducting system with one of the bundles blocked. Let us now look at the features of the QRS in normal conduction. And you can see here with this illustration, particularly on the right with 100 milliseconds, there is a dominant, but although very narrow, R prime. This is called a Crista supraventricularis pattern. Crista supraventricularis is a band of muscle that separates the mid-right ventricle from the outflow tract. It is on the roof of the tricuspid valve. It helps support the valve, and it also helps direct blood flow from the body of the right ventricle through to the outflow tract and out the pulmonary valve. Now, the Crista supraventricularis is believed to be the last part of the ventricle to be depolarized, and hence the R prime. So when we have a right bundle branch block, as you can see above, there is a dominant R wave as the R prime in virtually all the illustrations shown, and I've looked through many of these and they're always similar. On occasion, we get what is shown in the middle there as a small R prime. But in all of these, you can see V6 has a narrow QRS as well, as we saw with aberrant ventricular conduction. Whereas with ventricular tachycardia, we have a dominant R rather than R prime, and V6 has very broad QRS complexes, very different to aberrant ventricular conduction. So now let's look at some examples. Here we have an atrial couplet, which, as you can see, has been said to be a ventricular ectopic pair or couplet. And we can see the classical appearance of the RS R prime and maybe a P wave beforehand. Here is another one. It's an atrial triplet, but it was called a ventricular couplet as well. So let us go through this and see how we evaluate this. Firstly, there is an atrial ectopic with no aberration. Then we have this so-called triplet or couplet. The first two beats are classical aberrant ventricular conduction, and there may be P waves as well. The third beat is later, and as a result of that is outside the zone of aberrancy and now conducts normally. So here's another example of atrial bigeminy with alternating right bundle branch block aberration. And you can see that the atrial ectopics there either conduct normally or with an aberrant ventricular conduction. There will be people in the audience that will question this one and say that this may be a rate right bundle branch block dependent and therefore is pathological. Here is atrial trigeminy with aberrant ventricular conduction. And again, look at the V6 and you'll see the narrow QRS. Now, let's have an example here of what appears to be a classical ventricular ectopic on a Holter monitoring tracing. There is no V1. There is no P wave. So we don't know if this could be aberrant ventricular conduction. Note that the initial deflections are similar to the sinus beat. So how do we determine whether this is a ventricular ectopic or is aberrant ventricular conduction? And this is simple by just looking for later ectopics. So here is the same illustration again, and the coupling interval in yellow highlight, and I've highlighted it to be seen easier, is from the peak of the R wave of the sinus-generated beat and the so-called ectopic. When it's slightly later, from 398 to 421, one can already see a change in the QRS configuration. Later still, and we can see now, the QRS is narrowed, it's identical to the sinus-generated QRS, and there's even a P wave. And later still, it is quite an obvious atrial ectopic. So the message is important that aberration on a Holter monitor, look for other ectopics. But the real interest of aberrant ventricular conduction is with atrial fibrillation. Here we have an illustration of aberration, first described by Gill and Ashman in 1947, and now known as the Ashman phenomenon. One questions why Gill wasn't included, maybe because people couldn't pronounce his name, nor could they spell it. But here we have the Ashman phenomenon with atrial fibrillation with a right bundle branch block. The important part is that what they described were the long cycle and short cycles. And you can see that there is a long cycle followed by the short cycle and the aberrant ventricular conduction. And this is what encourages, and we'll see other examples later, this encourages aberrant ventricular conduction. Again, V6 is narrow. So 1947, Ashman phenomenon, why was it important? Well, at that time, and indeed was when I first started in 1970, Digitalis was the only drug used to treat atrial fibrillation with a rapid ventricular response. It's derived from the foxglove plant, Digitalis purpurea and lanata, and the leaves were dried and crushed and made into tablets. And this is what I use to treat such patients. But each tablet had vastly different amounts of cardiac glycoside, maybe 10 times the difference. And what is interesting is Digitalis has a very narrow therapeutic window. So in a clinic, a cardiology clinic, when I saw the patients, it was the first question I used to ask was exanthopsia. And people have no idea today what exanthopsia is, but it is yellow vision. And this is what we asked our patients each time, because this is how one of the ways we determined whether the patient had digitalis toxicity. So we had a situation. Is it aberrant ventricular conduction or was it ventricular tachycardia? And if it was aberrant ventricular conduction, we continued digoxin, whereas if it was ventricular tachycardia, we stopped digoxin. So you can see how important aberrant ventricular conduction was in everyday management of patients. But atrial fibrillation is not the only abnormality that we look for. It also occurs, of course, with supraventricular tachycardia. And here is a classical case of a supraventricular tachycardia, 135 beats per minute. And as it warms up and gets to 175 beats per minute, aberrant ventricular conduction occurs with a classical RSR prime in V1. Here is a case which very few people would question whether this is a ventricular tachycardia or not. But when we follow in the Holter monitors and look elsewhere, we can see that here is the very rapid ventricular tachycardia, and as it slows, aberrant ventricular conduction disappears. 230 to 165. beats per minute. What about looking for P waves? Here is a ventricular run, and it looks in V1 like an aberrant ventricular conduction, and there are P waves present. And as the tachycardia slows with the last beat, you can see that there is normal conduction now. So again, as the QRS narrows, as the ventricular response slows. Another area where aberrant ventricular conduction occurs and can be confusing is with echo beats. Echo beats classically occur with junctional rhythm. So to the left, we can see a classical junctional beat. To the right, we can see a pink arrow showing retrograde conduction. And as a result of that, it conducts to the ventricle with a QRS identical to the junctional QRS. But in the middle, we can see another retrograde conduction, and now marginally earlier, and we have a classical aberrant ventricular conduction appearance. Here is another ectopic atrial rhythm, blue arrows you can see, and then there is an early ectopic beat. Again, this may be an atrial ectopic, but is more likely to be an echo beat, and you can see in V1 conducts normally. It is reported as a supraventricular ectopic, and it's normal conduction. Whereas later on in the tracing, one can see now the classical aberrant ventricular conduction, again probably with an echo beat, and now is called a ventricular ectopic. The difference between the two tracings is the long cycle, short cycle to the left, whereas we have an extra long cycle with a short cycle, once again encourages aberrant ventricular conduction. Can a sinus beat have aberrant ventricular conduction? Well, here we can see an interpolated atrial ectopic with aberration. This is reported as a ventricular ectopic or a ventricular couplet, and you can see there with the P wave with the pink arrow, aberrant ventricular conduction, and now there is interpolation. So the next sinus beat occurs and conducts, but it too conducts with aberrant ventricular conduction. Aberrant ventricular conduction can even occur when the native rhythm has a bundle branch block. So the native rhythm is broad, but we have two beats there of aberrant ventricular conduction with this atrial fibrillation, and there is a broader QRS seen. And we'd like to finish off with left bundle branch block aberration, which is very confusing because it's very hard to diagnose and we need clues. Here is an atrial fibrillation, a rapid ventricular response, and you can see that has a left bundle branch block configuration. It's called a ventricular run, and we really don't know if this is a ventricular run or aberrant ventricular conduction. So what do is we look at the long, short periods that help us make this diagnosis. And also we look later in the tracing and we can see the V run reported. We can see the long short, and it's a left bundle branch block. But before this, we can see once again the long, short intervals and a right bundle branch block. And so one of the features of a left bundle branch block aberration is that it frequently occurs together with a right bundle branch block, and this is the way it helps us make that diagnosis. Here is another one, a left bundle branch block aberration. We can see it begins with a rate of 165 beats per minute. It's called a ventricular run, and we also see that as it slows to about 150 beats per minute, we lose this aberration and it's a normal conduction. Left and right bundle branch aberration, as I said, can occur together. And here is an example of an atrial couplet with a right bundle branch block aberration. Now is obvious to the viewer. But when we had a run of supraventricular tachycardia in the same patient, the supraventricular tachycardia now also has what it's called a ventricular pair, but it's actually a left bundle branch block aberration, which as it slows goes back to normal conduction. So how do we differentiate aberrant ventricular conduction from ventricular ectopy or tachyarrhythmias? Firstly, we look for V1, and hopefully in your Holter monitors, a V1 can be extrapolated by the placement of the leads appropriately. We look for a P wave. It's usually with an ectopic, but also with a supraventricular tachycardia run. We look for generally the right bundle branch block aberration with the uppercase R prime morphology. We look for long cycle, short cycle, and we look for a narrow QRS in V6, which helps diagnose it from ventricular tachycardia, which is usually a much broader QRS. And of course, we look for elsewhere in the tracings. So what have I learned? Aberrant ventricular conduction may occur with atrial ectopy, echo beats, atrial tachyarrhythmias, usually a right bundle branch block, but it can also be a left bundle branch block. It's very important to recognize aberration in order to not misdiagnose ventricular tachycardia. I'd like to finish with a message. Somewhere in the world today, somewhere maybe in Asia today, a patient is having a defibrillator, an ICD implanted, not because of a ventricular arrhythmia, but rather aberrant ventricular conduction. My audience is not going to do this because you're a captive audience with me today. But tomorrow it's important that you recognize aberrant ventricular conduction and not make this inappropriate error. Thank you. I'd like to take questions now, and anyone wanting to communicate with me, there's my email address. We have some questions coming in now. I'd like to thank you all for attending today, and I hope you had gained some knowledge and understanding of this difficult topic, which of course can have serious consequences if not diagnosed correctly. The first question that came through was in regard to a left bundle branch block configuration. Are there any clues on looking at the QRS as to whether this is a ventricular tachycardia or is it a aberrant ventricular conduction? Sadly, I don't have the answer. We look for the normal clues, of course, the short and the long cycles. And we also look, of course, that is in the short episodes associated with atrial fibrillation or an atrial tachycardia, and we can see how they can come and go. But as far as the actual QRS configuration, one requires a 12-lead ECG to investigate this. And sadly, it is pretty rarely diagnosed as a left bundle branch block aberrant ventricular conduction when we have 12-lead ECGs. Most of them are actually diagnosed on Holter monitoring. The other question that came through is that why right bundle branch block and not always left bundle? Well, I did show the action potentials in a slide showing that the action potential of the right bundle branch is longer than the action potential of the left bundle branch, and therefore the left bundle branch allows conduction, phase 3 of the action potential, and allows this for conduction to occur, and therefore we have generated a window, a window where the aberrancy can occur, and it's usually a right bundle branch block. The obvious questions is, why then is it sometimes left? Obviously, there are changes in the action potential duration, and therefore it can change from one to the other. We really don't know which one is more common. This is because it is much easier to diagnose right bundle branch block aberrancy rather than left. And then a third question was asked as to the importance of the axis. Well, this depends, of course, on the left bundle branch and conduction through it, whether it also allows it to go through one or both fascicles, and therefore you will have a left axis deviation or a left anterior fascicular block if that actual fascicle is blocked and is still in the absolute refractory period. They're the three questions that came through. Again, I'd like to thank you all for attending. There were 176 attendees today. Please do not hesitate to contact me by email. And I want you, if possible, to fill out the survey at the end. And this is important as to whether we have future ones. And if we do, then probably in June, I'll give another webinar on the wonderful, weird world of Wenky bark. Thank you all very much for attending.